Hey there, it's time to take the lead. Trust your voice, know what you need. Let's break it down.
Welcome to Beyond Clinical Walls with your host, Dr. Bayo.
We'll claim your life.
Picture this. Your friend, sister, or parent just called with news that changes everything. They've been diagnosed with cancer. Suddenly, you're thrust into a world of medical appointments, treatment options, and conversations filled with terms you've never heard before. Staging, grading, biomarkers, treatment protocols. It feels like everyone is speaking a different language. And you want to be the supportive, informed person your loved one needs, but you barely understand what's happening yourself. You're not alone in feeling this way. The American Cancer Society estimates that nearly 2 million people will be diagnosed with cancer this year, which means millions more family members and friends will be walking alongside them, trying to figure out how to best support someone through one of the most challenging experiences of their life. That's why today's conversation is so important. We're breaking down Cancer 101, everything you need to know about diagnosis and treatment, so you can show up informed and empowered, whether you're supporting a loved one or advocating for yourself. And we have the perfect guide for this journey, Dr. Sanjay, widely known as the OncDoc. Dr. Sanjay is a hematologist and medical oncologist at Citrus Oncology and Vice President of Clinical AI Operations at Tempus. With over 750,000 followers across social media and 20 million views, he's become a national voice at the intersection of oncology, innovation, and AI. His podcast, Target Cancer, has reached over 4 million downloads in 120 plus countries. Like me, Dr. Sanjay has made it his mission to translate complex medical information into content that actually makes sense. Dr. Sanjay, welcome to the show.
Thank you. I'm so excited to be here. Amazing voice. I could listen to you forever.
Oh,
It's just so comforting and warm. So thank you
thank
for
you.
doing that with this important topic.
Well, I am so grateful to have you join, and we are going to do some rapid fire questions. But first, for those who don't know, Dr. Sanjay and I met at the Next Med conference in San Diego. And I just want to share with everyone that I was immediately impressed by your passion for patient education. And for our listeners, I want you to know, as you get to hear all of the great insight that he's going to bring forward, whether you're listening to him, whether you see him on social media, or whether you get to talk to him, it is a through line. That continuity of what you see and that passion and that love is all there. Let's dive into some rapid fire questions that will give us some insight not only into who you are, but also your expertise as an oncologist. First one is, what did you originally want to be when you grew up?
I originally actually wanted to be a middle school science teacher, probably physics.
Hey, very nice. I mean, there's still some physics there, so I'd like to say it's still happening.
Yeah, the doctor term originally was it means teacher in Latin. So that's why I think it's a nice continuation.
I agree. Okay, your go-to drink at a coffee shop.
Pretty straightforward and boring. It's a medium vanilla latte.
Hey, very nice. What's the most important lesson you're instilling in your kids?
I think by far the lesson is be kind. Be kind and listen to your gut. If something doesn't feel right, just listen to it.
That is something that they can carry forward even in adulthood. For my girls, we do affirmations every morning, and I've been doing it since they were little. And it's like the simple ones that you hear, like, you are smart, you are strong, you are beautiful. And it's been amazing because as they age, I get to hear new things that they think about themselves. And sometimes if they're going through a challenge, I get insight into it. And the other reason why I do it, and I love that you do this as well, is as far as being kind to yourself, because there's so much out there in the world. But if we can lead with kindness for ourselves first, my goodness, that is a wonderful way to protect yourself and arm yourself with all the negativity or things that are coming our way. I love that. Okay.
Yes, it hedges against any kind of guilt, potential guilt or regret. It's like if you acted in kindness, you're probably going to be fine.
Yeah, I agree. All right. What's your top cancer prevention tip?
Believe it or not, there's a ton of data coming out, and it's always been there, but even stronger on just exercise and nothing crazy. I mean, literally getting your heart rate up, they say as little as 6 to 7 minutes if it's
Mhm.
strenuous, could have 25 to 30% reduction in your chance of cancer in your lifetime.
And a lot of people aren't aware of that kind of easy tip of something that you can do even once you walk out the door, maybe park a little bit farther. That can
Yep.
be just that kind of being able to implement that. All right. What's a common misconception people have about cancer?
I think by far the one that concerns me the most is that it's genetic, that like
Mm,
most cancer is because of an inherited genetic mutation or something, which is just not the case. 90% have nothing to do with the genetics that you were given, quote unquote, in your family line.
that part's important, but it also makes me like breast cancer. People are surprised to know that family history, that genetic piece isn't a part of it. The majority didn't have that. So
Correct.
that's why this conversation is so important. If you could get every newly diagnosed patient to understand one thing about their diagnosis, what would it be?
That's a hard one just because I have a couple of things, but the most important, I think, is that it's not their fault. There's nothing that one can do that is the reason necessarily that you get cancer because something as bad as smoking that we know is related, most smokers don't get cancer, right? So you can never just call it, I caused this or this is my fault. So that's very important that people understand.
It's huge. What's one question you wish every patient would ask their oncologist, but rarely do?
There's also a bunch of answers here, but I really think asking about how many trials or if trials are offered, and I'll explain why, because that number can trigger rightfully so, but when we talk about it later, you'll see how important that is.
Fantastic. Okay. Well, thank you for playing along. And let's get into the conversation. So, the first thing I'd love to talk about is, we see how overwhelming you and I, just as physicians, of course, you see it more than I do as an oncologist, but how overwhelming a cancer diagnosis can be for patients and families. So, therefore, I'd love to start with just the basics. When someone hears the word cancer, what exactly does that mean?
Yeah, it's a question that's glossed over, but I think it is so important to really understanding why it's so challenging. And that's because please understand, cancer is not a virus, a germ, something that you catch, something you treat with antibiotics or antivirals. Cancer is literally your own cells behaving badly. They're actually not regulated. So, the same way that our fingernails know not to grow to our first knuckle, or lung tissue doesn't grow into our chest wall, all of this stuff that we take for granted they just listen, they behave, they shed when they're supposed to, they die, everything works the way it's supposed to until it doesn't. And all of a sudden, this colony of cells in your body, they care about one thing: survive, grow, don't listen. They feel disconnected from the environment. They're no longer orderly. And so now you're trying to treat something and potentially hopefully kill something that is and has the same properties and everything that are your own cells. And that's why when people are like, well, how come we haven't beat that thing yet? What can you do to attack your genetic inherited? I mean, it has your genetics and everything in there. What can you do to just attack it so easily while not damaging something in your own body? And I think that's very important to understand on why it's challenging. And really, you're trying to tackle hundreds and thousands of years of evolutionary fitness. Like our bodies, we're around today because of the gazillion fail stops we have upstream and downstream. And when you're trying to put a cancer under duress, it does all of those things that basically have been selected out to be the reason we exist today. It's quite a challenge for that reason.
And just having that foundation of how you mentioned, it's not like your nails are growing towards your lungs. All of these things have a regulatory process.
Yep.
And when they behave badly, like you mentioned, that is the reason why there is a cancer in your body, and understanding how challenging it can be when we walk around, there's all of these environmental toxins, there's food toxins. We're just living life, that evolution of life, trying to pinpoint and target one specific area behaving badly is very difficult. And I really appreciate helping listeners not only know what cancer is, but that imagery of understanding what is happening, because there's so much misinformation. And when you attribute it to a virus or something else like that, it's easy to go down a rabbit hole if you don't have that foundation.
So we have signals, obviously, to regrow like blood vessels if we get injured and all that stuff. Like we have all this stuff in our toolbox. This thing sends out signals to get more blood flow to it because that's the nutrients. It sends stuff to be able to hop off and go other places. I mean, everything that we take for granted that we're doing all the time, it uses any and every tool in some place of your body so that it can grow, spread, and have a higher chance of survivability. So when somebody says like, "Oh, you could just take this, take that," it's like, how fundamentally could taking or consuming something just go and select for this same tissue that is your tissue all over your body and nowhere else and not hurt you and just kill that when all of it's the same, the engine, the acceleration, the fuel you put into it, if it's diesel or not, all of that still applies to your normal cells, right?
That is very powerful. I want to uplift what you just mentioned. You hear about supplements, different places that are things that will cure all. I would ask everybody listening, think about how could that one
Makes
product
sense. Mhm.
really be that engine to steer all of the areas that make up who we are? And that should be that gut check or that credibility check of what they're selling isn't true. And the other thing I also highlight is when it's an all for one catch where someone is touting, oh, this saves everything. If that was the case, wouldn't we see a difference? Like, those are the two things I ask my patients to think about when they are exposed to these misinformation or these all for one cures. And I'm so
Yeah.
glad we're highlighting that. That leads me to you've seen thousands of patients, and I would love to know what are some of the most important questions that someone should ask when they're first diagnosed with cancer? Because it can be quite overwhelming, and it's where do I start?
Yeah. I think the most important thing is what is the stage of my cancer? Because the moment you start looking stuff up, if you don't know it's a 2B, 2C, 3B, 3A, 3C, like all of the recommendations change based on the stage. So if you're going and saying, what do you do for breast cancer? But you're a 2B or a 3A, you're going to be drowning in confusion and the concern that you're being mismanaged. So you have got to know the stage to a T. And then again, that's because the guidelines are different. A stage, very simply, is how far along is this cancer, which directly relates to the chances of it coming back or not. So stage one, two, and three are all traditionally curable. It means like you should be cured of this, or the goal is to cure you of this. Stage four, otherwise known as metastatic, means that it's left the site that it originated and is somewhere else and technically not curable, even though with things like melanoma and kidney cancer, they're becoming curable now, even with stage four, which is amazing. But that's the most important is what stage am I? Because that outside of what cancer is it, right? Breast cancer, colon cancer, etc. The next question is what stage is it? Then if it's breast cancer, you have to know the receptor status. Like they are three different cancers. That's where hormone receptors, is a characterization are positive or negative are two different cancers, two different treatment regimens. So if I Google how do you treat breast cancer, nothing matters if I don't know the receptor status. So receptor status for breast, know the stage for all of them. And then the question then becomes if everyone could make a habit of saying, what are the most up to date guideline recommendations for the management of this cancer? So, not like, what are we going to do? What are we going to treat it with? Because, like, there are options. And
Mhm.
I can tell you there are doctors better than me or like more knowledgeable in this type, that, and the other, and those worse. Nobody has every single thing perfect. They need to look it up. Anyone can look it up, like, hopefully, if they're a competent oncologist. Just asking that question alone completely changes the way that interaction is going to go because now you're educated in saying, I'm requesting that the options in front of me are the guideline recommended. And those are evolving way too fast, which is why I do AI now for a significant period of my time because everyone knows it. The oncology community knows it. And healthcare, they just say it's the best we can do, a general oncologist. But in an ideal world, everyone says we would have just a specialist for each type.
Mm.
I think AI is going to
Yeah.
help us permit that. But those are the most important things or to understand and then be able to start empowering yourself with stuff I'm sure we'll talk about later and that you know very well.
Now that we've set the stage of we know what a grade is, we understand what cancer is. When someone gets diagnosed and they're hit with those terms that now we know about with staging, grading, and we'll get to biomarkers and treatment protocols, can you break down that diagnostic process and what a patient should be thinking about now that they know the terminology. What's the next step?
Yeah. So when you get a diagnosis, it's almost always with a biopsy. Okay. And biopsy is tissue in the needle that you throw onto a slide and then you stain it with different ink, like colors, to see what receptors they are. Meaning the proteins, they stain different colors. Like something that's sticky is going to stick blue, and something, if you don't have it, won't have blue, blah, blah, blah. That is called histology or the pathology. Now, you can have a grade to it, which generally a high grade, anything that's high grade is more aggressive. It's less recognizable. It's more taking a lot of the different tools in its toolbox versus a low grade, are generally less aggressive. Now, by far what matters more is a stage, but then within that stage is a grade. Just says like, how bad is this? If you hear high grade, generally it's more aggressive. But a high grade 1 is a different situation than a stage 3 that's low grade, because stage 3 is concerning because it's further along. So stage is the most important thing. Grade tells you how to differentiate or not. That's also on a slide. The biggest thing that is a huge problem that a ton of advocacy groups are trying to stress across the country is, the question is, do we have sequencing or molecular testing? That is not something that you can ascertain or figure out on a slide or under a microscope. And it is the entire way that you're able to get non-chemo targeted therapies, immune therapies, and all these other immune therapy you can do on a slide technically. But that's the way you get modernized treatments. And any stage 4 patient or metastatic has to have, to your point, biomarkers. That is the same thing as sequencing, or if you were to ask, did we get genomics or did we get molecular? Those are all the same terms, the same bucket. That goes well beyond what's on the slide to recognize and isolate what may be potential targets, to characterize if it is a more or less aggressive form of the cancer. And most importantly, when we say trial is a treatment to see if there's a treatment that goes against that exact receptor. You won't even know that if you don't have sequencing or molecular. So those are the couple of things that are put together. Imaging, to have an idea of what stage it is. The histopathology, which again is the tissue under the slide. We've been doing that for decades. So if you want something more than what we've been doing for decades, you ask for molecular or genomic testing or sequencing, all the same terms, to characterize it further, to expand your treatment options. Now, with that said, stage 1, stage 2, sometimes the sequencing doesn't matter, but it never hurts to ask, because that's also how you get into trials and learn your tumor better. In general, cutting out is always the best. If you have a colony of cells, right, it started at 1, 2, 3, 5, 10, now it's 100,000 or 2 million, you need millions to see it on a CAT scan. Why wouldn't you want to take that out? If you have a mole in your hand, you want to cut it out and liberally so you have good normal tissue around it. Think of that same concept in the lung and breast. That's why the best case scenario is just to take out the colony or village that went rogue, again, liberally, and have a bunch of normal tissue around it called margins. That's what you check. Did every single thing at the place of cutting, are they normal? Okay, good. I think I got it all. That's always the best case scenario. And that's what you're doing in early stages.
Well, and it goes back to with that bad behavior, if we can take it out,
Mhm.
so then all of the healthy tissue can really flourish. That is a win in helping your overall body be able to recover and remove the chance sometimes. And of course, this is, patient dependence of recurrence. And as we move forward, now that we have a staging, we have talked about diagnostics and biomarkers, and we even hit on clinical trials, which we're going to go a little bit deeper. All of this really highlights some of the barriers that are in place in our healthcare system for that patient as they're trying to navigate this journey. And that brings me into the question of healthcare disparities. In your experience, there's a lot of populations that are facing huge barriers to getting quality care. What would you say to a patient who is from these communities that they're trying to, now they have this information, what can they do to advocate for themselves when they see their doctor?
You don't even have to be from these communities. If you're a person of color,
Yes.
at all, you have an increased chance of missing the things that are standard of care, especially when it comes to molecular testing. I don't know what it is, but if you are Black, Latino, and there are a couple of other demographics, less of you are actually getting the molecular testing for your lung cancer, which can actually keep you alive for years longer. I don't know why. Like, it's so shameful, but it's up to 10 to 15%. Caucasians will be single digit percentage. But that's just one example of the diagnostic process, which has quote unquote therapeutic implication, meaning what therapies are available to me. The only way you know that is getting molecular. If you're a person of color, you have a higher chance of that not being ordered, which is insane. Additionally, there's plenty of statistics that show that the time to diagnosis is delayed in a lot of cancer types, as well as the time to treatment. So the sad reality is you have to keep calling and pressing. If it's like 4 to 6 weeks and you haven't had a result from the biopsy or the treatment plan hasn't been set, you just have to do it. And I wish I knew so I could fix it exactly why, other than just, sickening realities of why that's the case. But there's no question that if you feel this is taking too long to be able to go see him, just call. Because like I always say, you want to hedge and mitigate or reduce any chance of regret or should I haves in the future. Goes back to the gut thing that we talked about with my children. It's like, listen to your gut. And being an own advocate is not being shy about calling. Would I regret this if the ball was dropped? Unfortunately, it's the best we can do right now. I think AI, things like ChatGPT and Claude and whatever, have greatly changed and transformed the way people are able to advocate for themselves in a way that I couldn't say 2 years ago. I'd have to say, go to this group, listen to my social media, which is a joke. Why does social media make sure somebody gets the right care? Like, that is an embarrassment, right? But it was a reality, and you see it by thousands of comments now. But I think AI has really made it to where we can empower ourselves better by doing the search stuff that we'll talk about, I'm sure.
Yes, because when I think of AI and how it's able to bridge that gap or at least reduce all of the barriers that are present in our healthcare system, it can give you a leg up in being able to have that information, which helps foster that conversation. And one thing I tell my patients is when you're in front of that doctor, set a timeline and say, in 2 weeks, 3 weeks, pick a deadline that this is what we're going to do at 2 weeks, and even if that information, we know sometimes results still are delayed, but having a time that we are going to connect again is very helpful because then at least it puts you on the road for hopefully reducing those things that are falling through the cracks. Even that one conversation and say, hi, Dr. Sanjay, I would love to in 2 weeks. After you've already ordered these tests for me, let's have an appointment. Or what should I expect at 2 weeks? And if I haven't, what should I do? And that can be powerful. And then you bridge it with AI. My goodness, there's a lot of power there. So then my next question, it brings me to there's a lot of treatment options out there. And when someone is diagnosed with cancer, they're going to have all different kinds of things coming at them as an opportunity to help with their journey. How should patients approach understanding their options, whether it's what the doctor is sharing, what they're seeing on social media? How do you navigate this?
Yeah. Before we get even to more adjunctive or complementary stuff, this thing is going to sound like a busy answer, but it's extremely important. And that's that, like I said, we always want to, in general, the mantra was always cut stuff out because that's the bad colony. Again, think of the mole, like think of a melanoma or a mole. Like, what do? You cut it, obviously. Like, that's the same thing on the inside of your body. One big problem we have in this country, especially if you're a person of color or, and to your point, in a community, of just depending on what the education status is and how many oncologists are available. If you go to a surgical subspecialist, and this is nothing against surgical subspecialists because they're phenomenal. They're always meeting the needs of their area the best they can. You have got to ask, do I need to see a medical oncologist? Because stage twos and threes, with breast cancer and some others, were always just cut out. Like, the problem is there is data that shows with lung cancer, with breast cancer, with bladder if it's unresectable up front, or skin if it's unresectable. But especially, let's just start with breast and lung alone. And OBGYN also, and urology, all of these. Do I need to see someone? Because the data has shown that if you get treatment before taking it out, that you live longer, that your survival is better. So it really haunts me to this day that when I post this stuff, to educate women that, hey, if you have a stage 3 and it's triple negative, but the receptor status, meaning they're all negative, or a receptor that we know needs treatment, like immediately in a stage 3 setting, breast cancer, if it's HER2 positive, when I would post that to say, see a med onc, get treatment before your surgery, I would have 29-year-olds going, wait, so when I got surgery up front, like I didn't get treatment, I didn't get sent to a med onc, was I mismanaged? The answer is yes. And it's sad and it makes you sick, but that's because not necessarily anything was intentional on the breast surgeon's part or the OB-GYN's part or whatever. It's just these guidelines update too quickly. And that's why in lung, we've learned that too. The treatment before then doing the surgery can actually help you. So I know that's a busy answer, but it's very important to realize a medical oncologist is who gives you the systemic treatment. So when you ask what treatments are there, systemic means the stuff in your IV or by mouth nowadays. That's immune therapy, targeted therapy, chemotherapy, anything that treats like head to toe throughout your body, that's a med onc. Then you have surgical oncologists, breast surgeons, OBGYNs, urologists. They're cancer curers. They cut it out all the time, but a med onc is very important. So to answer your question, inside the med onc world is chemos that are standard, still big role for them in curative settings at the very least. There's immune therapy and there's targeted therapy. That's how I want anyone to think about it. If you ask, what are my targeted therapy options? That's usually where you also want to think, do I have molecular testing? Because you won't qualify otherwise. Immune therapy is great because it allows your immune system to kill the cancer. Immune therapy just literally allows your immune cells to kill it, and you can get cures with a stage 4 setting in melanoma. How ironic is it that really just going back to the basics of what our bodies have all done for us to this day, it has saved us from cancer multiple times to go back to the basics, and it's extremely efficacious to re-engage that system. That's why you hear about CAR T therapy and vaccines and immune therapy. Those are all the same stuff, which is let's let our body does what it does really well and has always done. Use the immune system to kill the cancer. Now, outside of that, you have surgery, you have radiation. Radiation is often used not only when you can't do a surgery, but sometimes even after the surgery to kill anything that might be in the area we couldn't see. Because to see it on a CT scan, you need literally millions and millions of cells just to be a 3-4 millimeter lesion, right? Let alone with the naked eye. So if the surgeon says, I got it all, you do a study and you see how many people still ended up having a recurrence, which is really a persistence. And if you see the number is high, then you know that there needs to be something else. Is there any other action we can take so that more people stay cured, right? That's called adjuvant therapy. With all that said, now you're like, what about all the other stuff? I don't know of a single supplement or herbal or anything like that that by itself treats cancer. Improve potential outcomes? Yes, that is a fact. And if a doctor says none of that matters, I think that's a red flag to consider. There is definitely mattering when it comes to diet, nutrition, and supplements that can influence one way or another. But I don't know of any that's a catch-all that just, somehow targets like a sniper the cancer and nothing else in your body.
There's so many gems that were dropped in that conversation, and I was hoping that you would go there, and you did. I, as a family medicine doctor, I steer my patients to that medical oncologist first because just like you mentioned, this notion, yes, we want to remove it or cut it out, but there are studies that show treating it in advance will help you live longer, will help you have better outcomes, all of the things. And if you break it down to there's an illness, there's something sick. We need to treat it. And then, of course, get rid of it. But as time goes on, if you can't get scheduled for that surgery for 6 weeks, 8 weeks, 12 weeks, or let's just say we talked about how the science is in a perfect but imperfect world. And let's just say that all of the areas of that cancer wasn't removed, but you saw that medical oncologist and you had treatment ahead of time, that is also a way to reduce those complications, improve your outcomes. And there's all of those layers. So I'm very excited when Dr. Sanjay was talking, I was just smiling and trying to not over, I was just joyous. And the
Yeah.
reason why is because this isn't talked about in that journey, that this is a huge component in a cancer journey. And for those of color, those of marginalized, underserved communities, and I use the word community because I often attribute it to we are all different intersectionalities. And I give myself an example. I'm a mom, I'm a wife, I'm a doctor, I'm Black. And so I subscribe to different communities. And same with you. So being able to uplift those communities that are often left out of this information is vital. And that's why I'm so glad we're having this conversation.
With that said, this being like, well, I didn't get treatment before mine. Did I get submanaged? It totally depends on the stage. Like
Yes.
stage one, there are very few that we treat before. Why? Because it's just unlikely that there are cancer cells that have left the site where it originated and are places we can't see. And we do studies on all of this. But then a two or a three, those cancer cells, as they replicate, you would never know that it's in a lymph node that's far away that doesn't get taken out during surgery. That's the thinking. Is like if it's a 2, 3, it's larger, it has features. That's why the stage is so important. That's where we learned, do we need systemic treatment to kill the disease that we can't see or know about? And who are the people that are most likely? So I just wanted to make sure that anyone, that it definitely depends on. And as we'll talk about, that's why AI is so helpful. You put your diagnosis there, you run it in a couple of things. Who cares if 1 out of 10 times, 1 out of 100 times are wrong? You can still ask the doctor. Nobody's gonna fault you. But if 4 of these AI agents are telling you that, now you have your answer, and you don't have to know oncology, which takes 14 years to do.
That is correct. And let's go back to knowing the guidelines. Therefore, if you are a stage one, you'll see the guidelines as far as if medical
Mhm.
oncology is a part of your playbook. I always call it your health playbook. Or if you're stage two or different, then you'll see that. So
Yep.
once you have that guideline and then you get the information and now you understand staging, you understand the biomarkers, that puts it all into perspective to know what journey that you need to go on because everybody is different. Here's a reality check. According to the National Cancer Institute, survival rates for many cancers have improved dramatically over the past decade. But these improvements aren't equally distributed across all communities. Access to cutting edge treatments, clinical trials, and even basic supportive care can vary significantly based on where you live and which healthcare system you're in. Dr. Sanjay, you work both in an academic and community setting. What advice would you give to someone trying to decide where they should seek care?
Oh, so this is a challenge and it's a complex answer. Number one, communities, one of the reasons that cancer rates vary is even just the access to the screening. So if it's hard to get your mammograms annually or the GI doctor, you can't get your colonoscopy exactly when you're supposed to, all these, you can imagine that if instead of a year, it's every year and a half or 2 years, the cancer is further along. And so, of course, the outcome will be worse. So, number one, like if anyone's listening, please, please, please try and get your screening. Includes lung cancer screening if you're a smoker. Like there's guidelines, just Google it. What are the guidelines to get and qualify for pretty much any insurance? Medicare, covers it, but it's one of those that are from Medicare and federal government says this should happen. Do I qualify for getting a CT scan every year because of my smoking history? But the point being is that's number one. Number two, once you have the cancer, yes, there's a whole bunch of factors that have to go with the reasons thought behind the responses being poor. There's some you can control and some you can't. Unfortunately, the reality is a lot of the treatments require going to the oncologist every other week or so, if not every week, if not every 3 weeks. And that's just not possible if some place is 6 hours away for a lot of people with just the cost alone. So I don't want anyone to have guilt with my answer or feeling like, oh, we're not doing enough, because community settings are obviously fine depending on the circumstances, especially like in earlier stage settings, et cetera, because you just need that surgery or sometimes the treatment lift isn't as big. But when you're talking about stage three, what we call multidisciplinary, you're supposed to have a CT surgeon on board and a med onc on board. And, the complicated cases that are high threes or complicated stage fours or technologies that just don't exist there. You're supposed to get radiation for this head and neck cancer, but you don't have a radiation center. There's no question that you need to go. And again, I couldn't say this 2 years ago because it's unfair for me to say that and a patient not know what they need. Now you know what you need. You literally go to these things and say, I am a HPV positive stage 2C head and neck cancer. What is the standard care of management? And they'll say, oh, or for stage three, like chemo and radiation at the same time. And so now you know that you need radiation, which is every day. And so you have to go academic. So all of that to say, number one, you do obviously the best you can. But if it is possible, and especially in a stage four setting, this is my opinion, like going to an academic center it gives you more trial options, number one, because a trial is a treatment. Every single therapy that's recommended in every cancer type in every line today wasn't a trial. There's not a
Right.
single one that exists. So if you want the newest thing or the next thing, the only way that happens is to get it on a trial if it's not approved today. And number two, if it's again multidisciplinary, where there's treatment before, treatment after, surgery, when do I do it? Those are the kind of scenarios that people would say to go to academic center versus if it's a straightforward, this is the surgery and it's managed with surgery alone. It's tricky to say the least. But I think that's where this era of being able to get an idea of what the optimal recommended guideline approach to your treatment is, and then go into your community center. If there's a mismatch or deviation, ask. I understand that the recommendations are XYZ. Y'all are offering ZYX. What is the benefit lost? And if they say that's the way to measure if it's something you can safely do or not.
What's the benefit lost? I'm going to repeat that because that really helps people think what direction I should go. And also, I love that you highlighted a clinical trial is a treatment. Every medication that you've had has been through a clinical trial. And we know that as physicians, but a lot of times patients are, it's overwhelming to even understand what a clinical trial is. I hear in the communities that I serve this thought, oh, they're going to experiment on me. They're just trying to put new drugs into bodies as a guinea pig. And I use that word guinea pig with history. My father, who passed away at age 99, he would tell me he was afraid of any sort of new medication, any clinical trial. He would say to me, Bayo, they just want to test on you like a guinea pig. And those are real thoughts that have gone from generation to generation. So, highlighting what a clinical trial is and for people to know it's medication that's already out there. Every medication was through that. So, I just wanted to uplift that comment.
But at the same time, there is truth or merit to that. There is
Yes.
some dark, shameful things that did happen at a time in medicine that are horrific to read. That makes me embarrassed. I mean, I'm 30 something years old. Like I wasn't part of that, but it still makes me sad on behalf of my profession, as a lot of things do, like civil injury and all these things. There was a time and a place that those things occurred for different minority groups, even during wars. There was a lot of scientific discovery that happened in dark ways. Like, that's all I can say. It's justified on where that came from. But
Right.
if, it is my opinion and in my anecdotal evidence of being in medicine now for 18 years, it's not that way anymore. Like, it's not. And if nothing else, I mean, yeah, and so, but that's where it's coming from. Like, that's, I always try with social media, take the truth of source of where something come from rather than writing it off, explain where it came from, and then explain how it's different today.
In order to understand the future, you have to understand the
Yeah.
history. And that's why I bring in my dad always into those conversations, those thoughts that he shared with me, because I have that in the back of my mind about the guinea pig and exactly what you mentioned. We talk about the Tuskegee syphilis study and all of the other studies that did experiment and how that is in the back of people's minds because they heard that narrative coming down the pipeline. So the more we can address that history so we don't pretend it didn't happen, but highlight what has happened moving forward is a way to build trust. It's a way to be able to deliver care in an authentic manner and help people because then we are honoring that past. Now, as we talk about the past, we're going to move to the future and how you are at the forefront of AI in oncology and how AI is, as we know, currently being used in cancer care. What do you feel patients should know about AI's role in their care and their treatment?
I mean, we actually changed our podcast kind of theme from target cancer to AI and healthcare just because it is so extensive. I will say this, okay, other than the fact that from a patient standpoint, it empowers you in a way, please understand when you go to ChatGPT or Claude or anything, it will only deliver as accurately as you ask it. So if you say, talk to me as an automotive specialist, that has no medical background on this type and stage of cancer and only use automotive analogies, it will do that for you. But if you don't specify your reading level or your profession or that I am not a doctor, it may give it to you and you may be like, oh, that's kind of a bummer. So you could say, put it in a table, put it in a graph, put it in bullet points, give me the narrative and script of how I should go into my doctor's visit and ask if I'm getting X, Y, and Z based on today's recommendations and tell me what studies and guidelines are quoting it. It will do all of that for you. You just have to say that. Now, I'm going to say this, and I'm going to disclaim that I am biased, but I feel very strongly about this, and I would never say anything that I don't do myself. The only way, and I hope this doesn't get me in trouble, but the only way we learn stuff is to share the observations of the world. I share the data on my Apple Watch, like my health metrics. There's identified and de-identified. So I don't necessarily mean identified data, which is a whole different thing. Most of the time, the stuff is, do you want to share in a de-identified matter, which is secure? We won't know the differences of a brown person or an Indian person or a Black individual or a Latino if we don't have the metrics of knowing who died of cancer, who didn't, who got toxic, who didn't. Because there's a big problem in the past where a lot of the trials just had, predominantly, a certain background or ethnicity, and that we don't know if that applies to us. But how can we expect that if we're not sharing those things? So the way that we really understand, the way I think AI can have a big difference on how quickly it makes our lives better with cancer and how much more treatable is how stubborn our institutions, it's not just patients, institutions, healthcare centers, businesses, how stubborn are they about keeping their data because they don't want someone else to get insight in the next billion-dollar idea? Because that's just less real world evidence to help guide us on what does and doesn't work. Because the reason people are skeptical on my socials, they'll be like, yeah, that whole thing's a farce. It's been decades, still haven't figured out cancer. There's some merit to that in the sense that there is a massive aggregate of human tragedy that has occurred from cancer diagnoses and outcome. And so the question that they're asking, again, going to the source of truth, they're saying, hey, a lot of people die from this. A lot of people have had horrific outcomes that don't respond, and y'all still ain't got it. None of that matters if you can't get the data of what was given, what was their type, what was the molecular, what was the cancer, what were their genetics. You don't have insight. So we're only limited to trials, which work really well. But understand when something gets approved, that process started on average 8 years ago. So you talk about technology, the newest kid on the block in our treatments started 8 years ago. Why? Because it takes forever to get the data, enroll in the trials, and then find the outcomes. So we're like years behind. That's where I get excited about AI. AI can actually crunch these numbers. It's so effing good, excuse my language, on knowing how long it takes to get to work at a certain time of day, right? Like you can put in 5 p.m. tomorrow and it knows the difference between that and 3 a.m. Not because it has a crystal ball, but because it has all the data to understand what the likelihood is. If you want that same degree of likelihood of responding or not responding, or being cured or not being cured, you have to give it the traffic data. And by this, I mean patient data. And so that's my biggest fear because I know it will happen. I just worry about the people in the year 2 or 3s of extra unnecessary delay potentially that suffered because of not being privy to that. And AI is the thing that's made it possible. You couldn't do that before with humans. Nobody's going to sit there and go to Memorial Sloan and MD Anderson, say, give me all this stuff. I'll just start running numbers and not get paid for it. Nobody. But AI can. And that's where I get very excited.
There is a play of gatekeeping that's
Mhm.
happening. Going back to the history part, how we talk about how have new innovations happened in medicine? It's through shared information. How do we work in medical school? We're talking to different people, we're sharing information. That is how you're able to coalesce and bring that information in the right way to help a person. And to your point, we are missing data when it comes to ethnicities. We've kind of coupled in race, but race hasn't really been a part of the conversation in the correct way. Let me give an example. You've heard me speak about how race is different than my ethnicity, and we have some clinical trials that have added that. But the bigger overarching situation is that population, that race or ethnicity haven't been a part of the conversation. And we are putting medications or having these trials that don't include us a part of the conversation, which means there's so much out there that we don't know that could make a difference. And two more points I want to make on what you mentioned. 8 years it takes for that clinical trial to, or that medication of what we're doing right now. Well, there was a study from the National Institute of Health that showed it takes 17 years for new evidence to translate into standard clinical practice. So when you add the 8 years
Horrific.
and the 17 years and that cumulative effect, we are behind the ball. So if we can utilize AI to expedite and find that bridge to help make it faster, that speed means more lives, means more people being able to live longer or be cured. And that's the reality of it, of what we're trying to achieve. So I just wanted to add that
No, I'm
piece.
so glad you said that. I mean, that's why I went part-time. Like, if it were up to me, I'd just practice full-time all the time, but it's this urgency because those are real people that if we don't shape how this is possible, and I do, that with Tempest now with the trial, how quickly now we can actually, like, match trials and drug developments, foster drug developments with data. That is what actually is gonna move the needle really fast. Let me give you one quick example on race, ethnicity, and something that's sad, and I think it's in part due to trust. If you have leukemia, most of the time, to be cured of it, you need a bone marrow transplant. So you need someone else's stem cells. If you are white, you have something like a 70% chance that someone registered themselves, like just showed what their blood type is. It's more than blood type, but bear with me. Like you just swab something. You have a 70% chance of having someone out there that can save your life by just giving you their stem cells. If you are a Black American, you have a 30% chance. Chances are that no one can swoop in and help. I remember a gentleman still that we had drives at Louisiana State University locally and stuff, trying to get it. Like, it was unbelievable. He had an aggressive acute leukemia, still in complete remission. We knew it was a ticking time bomb, couldn't find him a match. Like, that's because, like, I guess the fear of registration or whatever, but Indians aren't like near Caucasians either. That's just something so simple that if you're listening to this, you just literally say, register my bone marrow. They don't charge you anything. But it is the life or death for children too. Children that need the transplant. Every day they're praying that someone takes this action. And it's not like giving a kidney away. I mean, it's not a simple process, but it's not as big of a lift. You just give your stem cells and they're alive or dead. And it's a matter of registering.
That is life saving. And I go into this when you were sharing that story about leukemia and how race, which is technically a social construct, and then my ethnicity is different because I always say just because I'm Black doesn't mean I'm African, how we're missing the boat in where that treatment, where that match comes from. And if we focus on race, but maybe with ethnicity, is there room? Like, where is that information and how that data is impacting a life? Like,
Yeah,
that's huge.
it's
And
huge.
this disparity of 70% to 30% is beyond the numbers. It's a person's life. It's that patient that you just mentioned. And so that's why really reformatting how we look at medicine, how we use the tools that we have in front of us to help, it's crucial. And I want to give a plug because I think this part is very important. You had mentioned it earlier, but I also want to talk about your previous episodes with Target Cancer. You have like 75 episodes and it's packed with conversations with the newest technologies and treatments, and including that coverage of AI and oncology. The reason why I want to plug it is we've learned this ability to, in this episode, to understand the staging, understand the diagnostics, but having that fundamental piece, which is what you do in your podcast, is crucial. I normally say this at the end, but I'm going to say it now. Everyone who listens to his episodes, share it. Share it with somebody
Oh,
else because that is also a way how we're going to move that needle. I also want to highlight clinical trials, and we talked about the eligibility. Is there anything if someone's listening right now and they're like, I would love to. I didn't first, I didn't even know about a clinical trial or I didn't understand it. I would love to be a part of it or my loved one. Where would you ask them to start with?
so number one, if there's a clinical trial offered to you, you need to ask, how does this differ from standard of care? Because you might find that it's the exact same drugs plus one, or the exact same drugs and immune therapy. So you could be like, oh, well, that's a no-brainer. Or it could be like, well, actually, it doesn't use any of those agents and it does something else. That's how you get a qualitative understanding. You don't just say yes or no based on the trial. Your doctor should explain to you what and why this trial is being done, and really are doctors optimistic about it. That's important. So I don't want, if ever you ask for a trial, it never means you have to take it. It's just like, it
Right.
just means that you're seeing what you're a candidate for, especially if it's like they might say this is a more targeted form of the drug that's available right now, right? The second thing I wanted to say before I answered that is, to your point of experiments, et cetera, nobody talks about this enough. A phase 1 trial is still nothing as violent and horrific as it used to be, but a phase 1 means, is it safe in humans? So before, like, we had to just give chemos. I mean, that's how you found out. Like, I'm talking decades, not we as in me, but you just see if it's safe in humans or not. That's phase 1, not if it works, just if it's safe. So there are phase 1 trials, a lot now. Obviously, a lot of them, God willing, are safe and go to phase 2 quickly because we're so the understanding of these targets have gotten so much better. Sometimes they're just a matter of barely changing like one of the dials and having a new drug and still needs a phase 1 or whatever. Phase 2 means it's proven to be safe in humans. Phase 2 is to show that there's a benefit. And then a phase 3 trial is the one that's already been through the safety check, the benefit check, and the phase 3 is the one thing probably keeping it from getting approved. So just need everyone to know that. You just ask your doctor, are there any clinical trials available with my cancer in my setting? And then if they say no, then you say, okay, what about other settings in the future, other treatment lines? Or you say, how many clinical trials do you run at all? Period. That's the key. Because if the answer is no for yours, you might say, okay, I asked, but then you find out there's none in general in your cancer type, then it's not a place that has clinical trials, which a lot don't. Like, I focus on community, and my last 2 were community practices because they're always the ones that need care the most. They're underserved. So community care can be great. I'm a little biased, but I think I'm very, like, comprehensive with my patient management and like to teach and stuff. But you can always ask them, and I want to believe that they're a good person. Is this a setting? I'm talking about a stage 4 setting now, like incurable. What is the response rate with the current line? And if they say 30 or 40%, that's where you might say, do you think it's worth exploring a clinical trial? And most of the time, I want to believe they would refer you happily because now you're looking at something that's unlikely to work, which unfortunately is a lot of second line settings in a stage 4 cancer, second or third line. It's not over 50%. That's when people start thinking about trials. So you ask for their help. And if you don't have that, then you go to organizations. So Leukemia Lymphoma Society is phenomenal for cancers. Phenomenal. You go in there, there's a patient portal, you get a real person, and they help you and screen you in your radius and your insurance and everything. I've worked with them a lot.
That's
Support groups are huge because they can help with all the trial stuff. And then also Facebook groups and stuff with patients, but then also like the American Cancer Society or the breast organizations. Things are so accessible now. You just go to them for help. Don't delay. Don't think about it for weeks. Just do it. Just go ahead and do the trial, get that process started because it can take weeks sometimes to even be able to match. Don't just sit on the decision for that before the next treatment.
This allows someone listening right now to now have that conversation because you hear the words, you may not understand it, but now you do. And now, what do you say to your doctor? And based on that response, you've now given that person different options based on what that physician says. So that's powerful. And that moves me into you have very difficult conversations with your patients, especially if they are given a diagnosis of incurable or things look like it's moving into a hospice. What do you use as your framework for patients when they're facing these difficult choices about their care?
Oh, I mean, I think the one thing that can equip you most is to know your patient. And unfortunately, a lot of doctors aren't in a setting where they can get to know, which is sad. But for me, it really all comes from the relationships. There's so much trust that's earned in both ways, and like trust and respect and discipline, and it just like you go through things together, you know what I mean? And you have victories. I think one important thing is, especially in stage 4, people can live years now, like with no detectable disease for stage 4. It's you got to celebrate the victories. That's the big thing I say. Like, I never mean to patronize when I say this, but like, truly, we all are actually, we're going to die. I try to say it bluntly to remind most of us don't fixate on the fact we're going to die, right? But like, we are. But when you have a cancer diagnosis, it's a whole different thing, and it almost devalues or takes away the enjoyment because even though the same thing applies, it may feel sooner, especially in an early stage where you don't know that anyone will ever recur. But then it's so much is taken from them because of that fear. So you celebrate the victories and you always make the best informed decision you can. Then when we get to the point, if it has to be a hospice conversation, then now you have that reassurance of we made what God gave us, the world gave us, whatever you want to call it. Every best decision we know and we can say we took the ones that we believe to be the best ones. And we talked about it and we looked it up because then it's out of hand. And a lot of times when we have a decision, do I do another treatment or not? Do we do radiation or not? I say, which is the one that's going to make you have more regret potentially in the future? So one case is when it's a soft recommendation to do chemo after a surgery. So it's a stage 2 or 3 and it's optional. Some benefit, but like not necessarily whatever. And or there's a benefit and they don't want to do it. I say if it comes back, which is going to be harder for you? If it comes back and you say, I know I should have done it, like why didn't I do it? And you and your spouse, who has to be here, God forbid, if you were to pass, have to live with that decision forever. Or if we do it and there's the bad outcome and you end up getting admitted to the hospital or really sick, are you both going to say forever, we knew we shouldn't have done this. Why did we do this? And live with regret in that circumstance. So you take the worst thing out of both scenarios and you will be shocked. 9 out of 10 times immediately you get an answer. Oh, I would definitely have more regret on this one than the other one. Like it's like all of a sudden that it's clear. And again, it sounds silly, but I think it's very effective just to almost imagine your future self, and that's how you hedge against future regret, both as a physician or the provider and as the patient and the spouse and the family. Please understand as a loved one, your decision, even though even with your best intent, is not always the same or aligned with what that patient would answer. And then now you're in a situation where you could potentially have guilt because you didn't know you made them want to do something one way or the other.
Those are powerful words, not only for the patient, their family member, and even the physician. And the ability to forecast that prescriptive journey is vital. But if you forecast and you put yourself in that position of what would I want to do if this happened? How would I navigate that? As you said, that answer becomes very
Mhm.
clear. And then it takes away all the worry, the guilt, the rumination that can happen in our minds from everyday situations. And I also want to highlight celebrating the moments in life that are happening that are positive. That's something that I think everybody should be in tune with every day.
Yeah.
Every day, celebrate one thing that was good because you opened your eyes. You were able to take in a moment that you might not have been able to.
Yeah.
And that is powerful for everyone.
I'll even celebrate when they come for their tox check after the first week. I'm like, "Hey, high five, you tolerated it." Imagine if you had a bad response, an allergy, or intolerable. I have to throw away first line right now. Like it's already done, and it was supposed to last us an average of 14 months. And they're like, "What?" They're like, "What am I? What?" I'm like, "You did it. You're here." I'm like, "Are we doing this again in a couple of weeks?" "Yeah, of course I'm doing it." That's a win because I've seen the tragedy of the other side. And then when the first response stable, it's like, that's a win. It's a very humbling field. But to your point, I finally have accepted that I'm old enough to where people actually find value in what I have to say as a mentor. And so when people ask me, do I go to med school or not, law school or not, do I take this job or not? I'm like, look, the gut feeling, like if you don't take this job and work gets worse or you still ended up hating it, are you going to forever regret that somebody else filled that? And imagine that a year from now they're in that position, that other person. Or if you were to take that job and it was not everything you thought, would you regret and say, I knew I shouldn't have? And it's like, it's amazing how many times they're like, oh, well, in that case, I'm like, that's the case. And it's unbelievable how much clarity it gives.
This puts you in that situation. So that answer that's already there comes out and you should grab it because that is the plan that you will be okay with. And that's an important piece.
It reminds me of the quote that says, I flip a coin not to see if it's going to land on heads or tails, but when halfway up, the side I really hope to see it on.
Oh,
Right? Like, that's a similar thing. It's like you flip it sometimes, it just presses you, then all of a sudden, halfway through, you kinda get this feeling of, "I hope it lands on," and then, like, boom, you have your answer. Now it doesn't matter what it landed on.
I love it. We might have to do a video about that.
There we go.
I have two more questions to ask. What red flags should patients watch for that might indicate that they need to seek a second opinion or switch providers?
Obviously, any doctor has to be careful with this question, but I'm just gonna be just blunt. I mean, number 1, if you don't feel heard, I don't think at that moment is time to get a second opinion, but you should give them a chance by saying, "I don't feel heard." Or like and in then the kindest way possible. Don't let it completely bubble over. Don't let it come, push you back against the wall where you're already having regret, not changing faster. But if you don't feel heard, I have to believe it is hard practicing in this country. There's a lot of moral injury. There's a lot of burnout and stuff. But if you say, hey, I just feel like, you don't remember as much or like about how we talk about the symptoms, whatever, they may get whatever at first, but I have to believe the human's going to come out and that you have a different experience. Now, if that doesn't happen after one morning, like I think, being heard is very important because if everything was done correctly and God forbid there's a recurrence and the family and the patient all felt that they were never really heard or there was just a number, whatever, if the recurrence is going to happen either way, somehow someone in that family or that patient's still going to think like, did they manage me right? Shouldn't we have seen someone else? I don't think they were listening about the drug dosing and all this. You're just going to start making up stuff. Like, even though the recurrence would have happened to the sweetest doctor and it was managed no differently. If nothing else, if you have a bad feeling about something or like feel that it's inadequate, whatever, just voice it. And you'll realize how much they do know where it seemed like they don't. Because my head sometimes is running because, when we have consults, it's an ugly field. There needs to be more oncologists. That's number one. And number two, I guess other warning signs is, especially with the questions I gave you, like the genomic sequencing, if somebody's just saying no to anything that you're bringing to them that is recommended, thanks to AI these days, like to me, that's a big one. I mean, that means you're not receiving standard of care and given an opportunity to correct it or at least explain it, not even afforded that answer, that opportunity. Like, I hope that doesn't happen. I'm sure it does. And I think that's important.
Well, to wrap up our conversation, if you could give listeners 3 key takeaways about advocating for themselves after a cancer diagnosis, what would they be?
I think number one, educate yourself now because it's super easy, right? With ChatGPT and stuff. Give it the context, what you do, what you are, what your fears are, all that stuff. Number two, don't be shy about asking for your records. Like, I want to just see what my cancer diagnosis is, like the actual path report, right? Nothing wrong with that. What's my sequencing? And then number three, using those terms of guideline recommended, are these guideline recommended? Bring them if like you're already on a visit after that. And then the clinical trial offerings. Between those three things, that is an immediate neutralizer of what is still a concerning issue that I think passionate people, huge inspiration such as yourself, are trying to tackle to right the wrongs.
Well, Dr. Sanjay, this has been a fantastic and valuable conversation. I really appreciate how you break down these complex topics for patients and families. I know our listeners will feel more prepared to navigate what can be an overwhelming healthcare journey. Thank you very much for just sharing your medical expertise, but also for the work that you do every day to make cancer care more accessible and understandable. For those inspired by Dr. Sanjay's insights, I highly recommend following his work. You can find him on social media as TheOncDoc. His original podcast, Target Cancer, is available wherever you listen to podcasts and is packed with 75 episodes of knowledge about cutting edge cancer treatments and technologies. And as of 2025, he's launched a new podcast called AI and Healthcare, which breaks down these complex topics in a digestible 15-minute episode. We'll have all the links in our show notes, along with all of the resource mentioned in this episode. Did something in this episode click with you? Share it with someone who might be facing a cancer diagnosis or supporting a loved one through treatment. Because here's the thing, knowledge is power, especially when it comes to your health. The more you understand about each diagnosis, the options, and your rights as a patient, the better equipped you'll be to get the care you deserve. You've got this.
Thank you so much. You've got such a good soul. My goodness.
You right back at you. Thanks for listening to Beyond Clinical Walls. If you learned something new today, please leave us a review on Apple Podcasts or Spotify. It really helps us reach more people who could benefit from these insights too. Hit subscribe so you never miss an episode. We've got amazing content coming, including great episodes with the health creators you love.
You've heard the truth, now take the lead. Stand for yourself, know what you need. One step closer, you've made your mark. Keep showing up and light the spark.